Good evening, everybody. I am Itzo Toth. I will guide you through this webinar. I'm a cervical cancer survivor, and I am also the president of the Mellow Flower Foundation in Hungary. And I belong to ESGO and ENAGAGE, the European Society of Gynaecological Oncologists, and its patient advocacy network. And I am running the Quality of Life Series project. I am very happy to have you all today. Our bodies are more than biology. They carry stories, experiences, wounds, and healing. Sexual health is part of our dignity, our joy, and our connection to ourselves. This year, our program includes 2 webinars that guide us toward the fuller understanding of this wholeness. The previous session explored sexual rehabilitation from an emotional and psychological perspective, while today we turn to the physical and bodily aspects, never forgetting that the two can never be separated. We are really honored to do this with truly wonderful speakers whose knowledge and dedication bring invaluable insights and compassion to this field. Thank you to everyone who joined us today. Your presence and openness really made these webinars truly meaningful. Also, I have to add that this evening webinar may be a little bit longer than the previous one, so please keep on being with us. This is the first time, and from this point, I really hope for a long time, thanks for AI, that we can offer subtitles in different languages, giving the chance for those who are not so comfortable in English. So here you can see how to turn on the subtitle. Please find the open button, and then you can find your language. And also, if you have questions through the lectures, you can ask the questions, or if you have comment as well, you can write it into the Q&A section. At the end of all the presentation, we will have time to discuss all the questions and, of course, all message you leave us. And we have a poll, so please, let's play a little. We have 2 questions before the lectures, and the first is, when you hear the term sexual health after cancer, what comes to your mind? Please choose an answer. Okay. I hope we are here, many of us. Very nice. And let's see. Okay. So, hope and healing, pain and loss. Wow. And taboo or silence. Very interesting. Thank you for your answers. Let's see the following one. We have another question for you, which is, how comfortable do you feel discussing sexual health in a medical or support setting? Very comfortable, somewhat comfortable, not comfortable. I have never had the opportunity. Okay, you can see the answer soon. Somewhat comfortable. Okay, that's great. That's good. And I have never had the opportunity, and also very comfortable. Okay, thank you for the answers. I think it was a little warming up. And now let's start our webinar. So I would like to introduce the first speaker. So Professor Dr. Katrin Kierherner, you must already know her, Associate Professor and Clinical Psychologist at the Department of Radiation Oncology at the Medical University of Vienna. She was part of the first webinar too and works with us on several projects. Her research focuses on psycho-oncology with special emphasis on quality of life and sexual health after gynecological cancers. She is a leading expert in the EMBRACE study, which has shaped our understanding of vaginal morbidity and sexual well-being following chemoradiation and brachytherapy in cervical cancer. Her work brings critical insight into both the physical and psychological aspects of survivorship, making her a key voice in this field. Welcome, Catherine. The floor is yours.
Wow, thank you very much, Itzo, for this very kind introduction. And I'm happy to be on board today and try to give a little bit of an insight into the physical side, into the most common side effects after treatment for gynecological cancer, and into self-help strategies directly for patients. So we did, I think 3 years ago now, a survey also coming from the ESGO, ENAGAGE, and ENAGAGE network on sexual health after gynae cancer. And the majority of those patients answering were ovarian and cervical cancer patients. And we were pretty shocked by the results when we asked if the sexual life changed after diagnosis or treatment, because 60% nearly answered, yes, my sex life became worse. And even 24% of survivors said, I'm not sexually active any longer. And in another question, we asked for their satisfaction with their sexual health overall, with or without partner. And already 1/3 were somehow dissatisfied and 27% very dissatisfied. And of course, I'm fully aware, also leading a sexual health clinics, about the common patient-reported sexual problems. And those are lack of sexual interest, lack of sexual desire, and even enjoyment, or difficulties with sexual responses such as arousal or vaginal dryness. Some patients complain about the feeling of vaginal changes and tell me they feel their vagina has shortened or tightened, which can lead to discomfort and also pain during sexual intercourse. Other patients struggle more with body image problems, especially around partnered intimacy, which can cause mental stress during sexual activity. Others complain about vaginal bleeding during sex or after sex. And lastly, also difficulties with reaching orgasm. So let's start with having a small look at the changes in the sex hormones, because especially a drop in estrogen, which is commonly associated with the cancer treatment, naturally leads to vaginal changes, namely vaginal atrophy, also causing vaginal dryness. So all the changes in sex hormones in a, let's say, healthy transition period, this happens over, let's say, 10 years. Of course, cancer treatment might lead to this abrupt deficiency in estrogen, and the changes in all the sex hormones can lead to a reduction of libido, but also to a disruption of the normal sexual response cycle. And in the next talk, you will hear a lot about the role of testosterone also in sexual desire and libido. So the changes that are caused in the mucosal tissue, the so-called vaginal atrophy, can lead to vaginal dryness. As you can see here in the picture, the mucosal tissue becomes thinner and also drier, which means that even despite sexual arousal, the vagina can not get as lubricated as before. And of course, during penetrative intercourse, this can cause a dry friction, and this is commonly experienced as painful to all the patient. It can additionally lead to irritation, even hematomas in the vagina, and microlesions that can cause possible bleeding. And with those little micro injuries, there is an increased risk of additional inflammation, as you can see in the picture here on the right, that will cause discomfort, but also the feeling of itching, a burning feeling of soreness, swelling, and might also cause some pain. A little special section here after pelvic radiotherapy, vaginal atrophy is of course also present. It looks a little bit different, but you can also see a thin and quite fragile vaginal lining that is easily torn. And characteristically, you also see a pronounced change in the color of the mucosa. And I tried to depict it here with vaginoscopies that we did in patients. First at baseline on the left side, you see a normal healthy vagina before radiotherapy with a uniform pink color. And you can also see the small vaginal folds are still present here. Same patient 6 months after treatment with a mild pallor in the color of the mucosa, and also the vaginal folds are already reduced. And on the right side, the patient 2 years after the end of radiotherapy with a severe pallor in the mucosa already. But again, this is quite special also after radiotherapy treatment. Also after radiotherapy, quite pronounced are telangiectasia. Those are small dilated blood vessels that you can see depicted here in a single area in a patient, and here in another patient where you have those dilated blood vessels in multiple areas. They are clinically harmless, but of course they can lead to contact bleeding during intercourse or after intercourse. And in some patients, this will trigger a fear of injury or also the fear of recurrence of the cancer. So what are common strategies for vaginal dryness and also the fragility and overall irritation? To use, first of all, vaginal moisturizer to rehydrate the mucosa, and those are applied every 3 days. And then, in addition to that, during any penetrative activities, such as intercourse, to use water-based lubricants. Importantly, they should be water-based and not based on silicone. They should not have any additional fragrance, and are also important to not use any oil such as coconut oil, olive oil, and so on. Third option that needs a prescription, so you cannot get it over the counter, is a local estrogen vaginal cream. Prescription is necessary because some tumors are hormone sensitive, and then you're not allowed to use hormone, not even locally in the vagina. Also, if you tend to have a quite irritated problems here, avoid any soap while showering. Also avoid bubble baths, and do not use any intimate sprays or any intimate lotions in this area. Vaginal atrophy can also lead to the feeling of shortness and tightness. This is, of course, also well known after surgery, and we will hear a lot about this later on from Dr. Unger. But also simply the vaginal atrophy will lead to changes in the blood vessels and also the tissue structure. So it can lead to a thinning and weakening of the vaginal walls that is most commonly experienced by patients as a loss of elasticity. So during intercourse, a feeling of tightness or the feeling of a shortened vagina can also lead to discomfort or to pain. And again, referring to the special situation after pelvic radiotherapy, we do know vaginal shortening quite well in radiotherapy as a long-term progressive fibrosis. This happens even years after treatment. It can continue. And to explain fibrosis, I make an analogy here, which is not completely correct, but you can imagine it as a scar-like tissue that is slightly thicker, less elastic, and more rigid. So with this vaginal stenosis after radiotherapy, you might have the feeling of vaginal hardening or vaginal shortening and tightening. And you can even see this on imaging here on the left side. This small white canal here is the normal vaginal length on an MRI, and here you would see a pronounced grade 2 vaginal stenosis after radiotherapy. So the hardening of the vaginal tissue can be perceived as a barrier that can be in one specific area where you have the feeling something feels not quite right, or also throughout the vagina. If the vagina shortens in length, you might perceive it as painful hitting the back. If the vagina is narrower than before, you will most likely experience a painful overstretching during penetration. And you can also feel the loss of elasticity, and all of this might lead to pain during intercourse. So regular strategy after pelvic radiotherapy is to separate the vaginal walls to dilate the vagina. This can either be done with medical devices that you can see here in blue, the vaginal dilators, or any surrogate can be used, but also penile vaginal intercourse is a good substitute for regular dilation. And it's important after radiotherapy to regularly dilate for a long period, even years after treatment. And it does not matter if you have or have not sexual interest or are interested in regaining the ability for intercourse. It's simply necessary also for a painless gynecological examinations, because you will prevent any adhesions of the vaginal walls. And we do have the assumption that there is even a certain stretching effect of the tissue, and this is still under discussion. However, vaginal dilation is included in all international guidelines and is regarded standard of care in the radiation oncology community. I will just jump over a little bit because this is for me really important. We do know from nearly all our patients that vaginal dilators are extremely uncomfortable to use. Many patients complain that this is a mechanical approach. Some even describe it as intrusive. And I completely understand that those hard plastic medical devices are not really inviting to use them. So we were thinking in our sexual health clinics for a long time how to make this dilation more comfortable to our patients. So now, since over 10 years, we offer vibrators in different sizes made of medical silicone, and they can come with or without additional clitoral stimulation that you can see here for the outer part of the glans clitoris. And this has a lot of advantages. So my tool bag in my sexual health clinics has now a very broad range of different vibrators in all shapes and sizes and dimensions. And importantly, before I recommend a tool to dilate the vagina, I will always measure the vaginal size regarding length, but also regarding diameter. And then I know how to pick the right device for the right patient, and always to use also vibrators with the water-based lubricant. And we could see in our outpatient clinic even a clinical advantage, because in order for the clitoral arm of the vibrator to reach the clitoris, the whole length of the vagina is dilated. So we see also clinically a great success in the prevention of adhesions, especially in the upper part of the vagina. But sexuality is so much more than only vaginal functioning. And vaginal functioning is only the tip of the iceberg, because that's necessary for penetrative intercourse. And I do acknowledge that the focus of medicine is very much on the vagina. But of course, then we have the rest of the iceberg, which is the clitoral functioning. And the clitoris is the most important female sexual organ for arousal and orgasm. So it's the pleasure, the organ for pleasure, that is extremely important. And then we have even the big ocean of psychosexual functioning, where we have a lot of resources hidden and a lot also of compensation strategy. So just to recognize, yes, it's important to dilate the vagina and to take care of vaginal health, but this is not the most important sexual organ. So looking at the clitoris, there are also, of course, after treatment, changes in arousal and also in the ability to orgasm. And we know that the clitoris is a quite complex structure with the small external part here that I hope everyone is familiar with, but also with a large internal erectile tissue that you can here see depicted on the right side. The upper picture is a flaccid clitoris, and on the lower picture you can see the erectile tissue in full erection. So after cancer treatment, there might be a reduced blood flow to the vulvar and clitoral erectile tissue, and that leads to a decreased sensitivity to any stimulation. So just be aware that sexual arousal after treatment might take you longer than before and might require more stimulation or even a different kind of stimulation than before. And also take into account that orgasms might be less intense or take longer to achieve. So not to put pressure on yourself, that things go back to normal, that things go back as they were before here. Another important role are the pelvic floor muscle. They greatly contribute to sexual health because pelvic floor muscle also promote blood flow into the pelvic area, the vagina, and also the clitoris because they share the same artery here. So if you have a well-trained pelvic floor, this can lead to more arousal because of higher blood flow and also more sensitivity. Moreover, pelvic floor muscle also contribute to vaginal lubrication, and they also contribute to orgasm with rhythmic contractions. So usually, if patients have some kind of discomfort or pain, or it might only be mental distress such as anxiety or tension, it will come to an involuntary tightening of the pelvic floor muscles. And this, you can see here the muscle depicted, and this tightening of the muscle will lead to further narrowing of the vagina, and this narrowing even causes more pain during intercourse. So there are a lot of strategies for a tense pelvic floor, such as stretching exercises, mobilization, but also, and this is really purely for you, for self-help, muscle release and self-massage of the perineum that is depicted here on the right side. You can start relaxation exercises, also breathing exercises, the diaphragmatic breathing, for example. You can try local application of heat, but you can also try an internal trigger point massage. There are some products already available for self-help here. And since a few years, there are also biofeedback devices for home use that are connected to an app and will give you great insight also in your pelvic floor. My personal recommendation, I hand out to nearly all of my patients an official medical prescription where I write down foreplay until orgasm before you try any sex, any penetration. And this is also, it has a good reason because an orgasm will increase the blood flow in the pelvis, and this in turn will lead to a higher vaginal elasticity. An orgasm will also lead to reduced muscle tension, and it also reduces mental stress to a great degree. So there is a high clinical relevance of sexual pleasure, of sexual arousal, and also of orgasm in rehabilitation. And this is true both in self-centered activities such as masturbation and in partnered sexual activities. Further strategies to reduce pain, to reduce tension and anxiety is a so-called pain buffer. a protective donut-shaped silicone penis ring that will reduce the depth of penetration, that can also decrease the expectation of pain and alleviate mental stress and tension, but also some counseling regarding optimal positions during intercourse. They can also reduce the depth of penetration. They can optimize the angle of penetration if it's painful, and they should also allow the maximum of movement control. And as a third option, to add some external clitoral stimulation while having intercourse, for example, with such a small finger vibrator. But the largest sexual organ to end with is not the vagina, it's not the clitoris, it's the brain, of course. So just having a glance to the psychosexual functioning, sexual activity is so much more than intercourse, and it addresses so many vital topics as sensuality, intimacy, connection, emotional bonding, curiosity, mindfulness, creativity, and so on. And we do not have time here to address the important topic of libido, but I would just like to refer you at the end of my talk that we jointly published also as an ENAGAGE initiative together with ESGO and ENAGAGE, a free self-help booklet for gynae cancer survivors that suffer from loss of libido. And I invite you all to download this little self-help booklet. It has been translated already in 10 languages, and there you can get great resources to restore your sexual health. Thank you very much.
Thank you so much, Catherine. It is always very nice listening to you. And thank you for the pictures as well, because they can help us more understand the issue. I would like to ask all of you here, the presenters, that when there is a question in the Q&A, please answer in written format. So, Catherine, I see that now we have 2 questions there. So please answer in written format there. And okay, let's go to the next presenter, Dr. Zoya Razumova. She is a gynecologic oncology specialist from Karolinska Institute in Stockholm, Sweden, dedicated to advancing both clinical research and patient-centered care. With a passion for improving outcomes in gynecological cancers, she has played a pivotal role in education, advocacy, and interdisciplinary collaboration. As a former vice president of ENAGAGE, Zoya has been at the forefront of shaping the next generation of specialists, fostering innovation in treatment approaches, and strengthening the integration of medical expertise with patient-centered advocacy. She is an active member of ENAGAGE EEG, deeply involved in sexual health after gynecological cancers, working to improve quality of life for survivors, and actively contributes to the ENAGAGE Quality of Life project. Her topic today is also very interesting. It is about testosterone. So go ahead, Zoya.
So, hi everyone. Thank you so much for a nice introduction, Itzo. It was like, oh, very nicely, interestingly written. Today I was asked to talk about testosterone and its role, or like try to explore its role in intimacy after gynecological cancer. It's very discussable like topic, and there is no like, it's not going to be like a didactic lecture like Catherine gave you with like a lot of tips and tricks. It's more like to give you an overview on that topic, that this topic exists and that may be something that would help you or like would be beneficial in your case. So currently, like I live in Sweden, so of course I read like local newspapers, etc. And local newspapers in Nordics are overloaded with testosterone news, like related to actually female health. So like recently, there are a lot of articles appears in the Guardians, the New York Times, etc. And more patients, like English-speaking patients, coming to me and asking like about testosterone. So not just like those who have or had like gynecological cancer, but in general, this topic is like becomes more and more popular now. And I'm sure you're also seeing some articles on that or like videos on that. So for a long time, it was like testosterone was considered or like was boxed into conversation about male sexuality. It's something masculine, it's something just for male. But like, does it actually play any role in the female sexual health or in a female body in general? And it actually seems so. There are a lot of like very smart words on slides, but I think the most important is that to say that testosterone, it's a considered to be a principal male hormone, also called androgen. It is produced not only in ovaries in female and testicles in a male, but also in so-called adrenal glands. And that's a gland that sits on top of your kidneys. So it is released directly to your blood, but like with the use of special process, it can also be converted from other hormones in the body. What is important to remember, and we're going to come back to that, is that testosterone is easily converted to estrogen. So basically, male hormone, or like this most important male hormone, is easily converted to like most important female hormone. And that's something that we need to keep in mind when we are talking about gynecological cancer or like quality of life after that. So yeah, as I told you, like it produces by ovaries and testes in the male and also from adrenal glands. It helps in development of the body, of a female body. It helps with the sexual anatomy, physiology, sexual behaviors. So it does play a huge role during the whole life, like from day one. And of course, we need to understand that the levels of testosterone in female and male differ. Like crucially, I would say, we usually say it's 10 times lower in women than in male, but it's between 10 to 20 times less, actually. As Catherine already showed in her presentation, the peak levels of testosterone are about like in the age of 20s. There is gradual decline with age, and but it doesn't disappear just like suddenly when there is a natural menopause. It decreases very, very, very slowly. And when there is a surgical menopause, it's a case when we remove ovaries, then it's called like this surgical menopause. Then this sudden fall in the level of testosterone happens. And then, of course, there are different like biological mechanisms that are going on. It's also interesting to, I actually was surprised that there are some studies showing that and quite big actually studies showing that actually a level of testosterone are quite high after the age of 65, 70. So it's very discussable. It's not something like that is a basis, but it's something to think about. And a study that was investigated this question, it is based on more than like 5,000 patients. So it's quite big cohort. So maybe actually those testosterone levels that do influence sexual libido are high, not only like in early 20s, 30s, but also like a bit later in life. And then like, why do I need it? Okay, I told you about this testosterone, some complicated like male hormone that we all heard about, like, but what does it have to do with my cancer or like with my sexual health? Actually, it does have. It's shown to be like to playing significant role in sexual health. So it does influence libido. But at the same time, there are some buts that we need to consider. So first of all, like if you think about using testosterone, you need to know that it should be used together with so-called hormone replacement therapy, or the usage of estrogen plus progesterone, maybe just estrogen. So you cannot just jump into testosterone directly. There should be a way, or like a path through this estrogen treatment first. So if you know, and like, how should you know whether you can have it or do not have it? And also, it's like varies a lot from country to country. In some countries, our colleagues are very conservative and they want to avoid any kind of hormones after treatment of gynecological cancer. They don't want to like prescribe anything that can potentially increase the risk of relapse or like bad outcome. But actually, it's a very small picture now, but on the slide, but it's very nicely described in which types of gynecological cancer you can actually get hormonal treatment as a part of your recovery process to increase your quality of life, to increase like the quality of sexual health after the treatment, like during the treatment. And then, for example, it really varies a lot. So we don't just talk about location. We don't say if you have ovarian cancer, then you can or cannot do it. It also depends on the molecular and specific variant of this cancer that you have. Like, for example, we usually consider this hormonal replacement therapy with estrogens in ladies who have cervical cancer connected to HPV virus. And that's actually the majority of ladies who have cervical cancer. But as I told you, it's very like, it's a big discussion. So I think as a personal advice, if you meet a person who is, or like a doctor that is responsible for you is very much against it, maybe you can get a second opinion. Maybe you can look for someone who can have a different view on that. But you can guide yourself based on this picture on the slide just to understand whether you fit in this category or not. And once again, it's like it's a common decision. So it's not just you who decide and not just doctor who decide, you should decide together. So when there is a hormone replacement therapy, or like we call it a therapy with estrogens, then there is a place for testosterone as an additional molecule. We need also to remember, why do I say that it should be based only on estrogen treatment or should be added after already prescribed estrogen treatment? Is that because, once again, like a magician, your body can convert this testosterone that comes to your body to estrogen. So if estrogen, like this female hormone, is forbidden in your case, then there is no place for testosterone. So it should always like comes together. And of course, there are like different benefits and risks, but we need to also think about other aspects. As I mentioned, it's like whether your type of cancer is hormone sensitive, estrogen sensitive. There are also other things like, for example, in case when a lady has different types of mutations that are connected not just to one type of cancer, but to like different types of cancer. The most common one is so-called BRCA mutation, when there is increased risk to get not only ovarian cancer, but also breast cancer. And for the breast is very sensitive to estrogen. Of course, we want to avoid it. So there is no place for discussion for use of testosterone, which, as I told you already, easily converted to estrogen in patients with BRCA mutations. So there are some limitations. And also, like, something to consider is that actually there are not so many studies on that. Testosterone is often ignored by like scientific society, by doctors, and by patients, just because they are not aware that it exists and that it can be used. Therefore, all prescriptions and all treatment that we do, they are based on like hormonal mechanisms. So we basically just like guess how it's going to work. There is very, very limited clinical evidence. There are some studies, but not like these big studies that we love. We call them meta-analysis and so on, that we base our daily practice on. So it's still like we should be very careful with that. We should not ignore it, but we should be too much generous with that. So you would like probably guess, in my opinion, we discussed it with one of our colleagues who's also present here, that there are different types of testosterone, different forms. So it's basically like you're choosing a color for to paint your wall, and you think, oh my God, there are like different. You can get shoot, you can get gel, cream, tablets, like so many different forms. Oh my God, I can choose from so many things. But actually, if you're a lady, and probably the majority of you who are here are ladies, um, there is not so much actually to choose from. The majority of countries, and actually all countries, are, and it's just one that has this official testosterone for female use. And that's the country that you can guess by looking on the left of the slide. And there is this very nice kangaroo hugging woman. So yeah, it's Australia. Australia is the only country in the world by October 2025 that has a female testosterone in a cream form in a concentration that is needed for ladies, for women. And what is the difference? You would say, oh, that's the same substance. Why couldn't I use like a gel or eye drops or whatever like that men use? And the problem with that, in ladies, the needed dose is only 1/10 of a male dose. And if you are talking about gel, for example, it's one pump, and then you need to have a half of a half of a half of a pump. So that's very hard to like dose. That's very hard to use, and that's for sure something that does not help us to spread a word, because you cannot spread a word when the drug or medicine that we need exists only in one country, which is for most of us very far away. So it's very important to think about female dose, this precise dose, good dosing. So you really need to measure it to like with a microscope. You really need to be very careful with that, because underdosing, okay, there is no benefit, but it's hard to underdose medicine with such concentration. Actually, in the majority of cases, the risk is to have overdosing, and in this case, we get different side effects. Almost all of them are convertible, actually, but anyway, I mean, there are like it's extensive hair growth, it's a change in a voice, it's different things that actually does influence quality of life. So how should we monitor it? Okay, I get, for example, I get estrogen, and then I get prescribed. I live in Australia. I get this like a female testosterone cream. What should I do next? Should I just like come for like one more visit in a year, in 5 years, never appear? Maybe I should just ask a friend who traveled to Australia to buy it. And the thing of that, it should be really carefully monitored. And there is also one more discussion on that topic. There is no consensus on that. What exactly should we measure, and what are the optimal level of testosterone? There are different things, like, I don't want to overload you, but like free testosterone, bioactive testosterone, etc., etc. So what exactly should we measure? What is the baseline? What was the level of testosterone before the treatment, before the surgery, before we removed ovaries? Maybe it was originally low. Maybe we shouldn't really supplement it. What I want to highlight is that if we're talking about a bit younger patients, so we're talking about those who are in their 20s, 30s, that's must have in the majority of cases when estrogen is allowed. So if you have a tumor, you checked on the slide few slides back that you can potentially have hormone replacement therapy. That's almost must for you to have testosterone together with estrogen, because the sudden decrease in testosterone and estrogen levels, that's not okay, and there are many, let's say, long-term side effects of that, including like cardiac problems, etc. So what is also important to say that testosterone level is not equal to sexual function. If you have a low level testosterone, it doesn't mean that you're not like having a high libido. It varies a lot. So it doesn't mean that if you have a low one, you have a low libido. Just like it's more complicated. You shouldn't really put an equal sign between those two things. But we should remember that testosterone can potentially improve sexual desire. And just interesting facts for you. I'm going to name two different things. And the first thing is a tibolone. It's a substance, so it's not a commercial name that I put on the slide. But why it's interesting, it's not approved in the US, for example, so it doesn't exist there, but it does exist in Europe. We actively use it in Sweden, for example, when we are talking about ladies who don't have any gynae cancer or cancer in general, who are just like entering menopause. And what is this tibolone, this substance? That is some kind of magical substance that can work as a hormonal replacement therapy for with estrogen, but also with progesterone, and also as an androgen. So basically, it gives you everything in one tablet. At the same time, those studies that we have on that and why it wasn't approved in the US is that the benefit is like it exists, but it's modest. And also in the US, they decided to wait a bit with approval because there are potential risks for breast cancer, endometrial cancer, stroke, etc. But it's again it's very individual. So it is allowed to use it in Europe, and check if you maybe have it in your country. Maybe it's something that you can and your doctor can consider. Then it's everything in one, basically. So there is also tablet form of that includes testosterone. What's important to say that if we are going back to the slide, that there are no trials that compare this tibolone, this like magical combined pill, with a regular testosterone. So we cannot really compare, but we know that it does work. It's approved in the European Union. The other thing, my slides live their own life, but is that testosterone patch. And we are talking about testosterone patch for women. There are for men, but what about like this female dose, this like low dose that we shouldn't like, cut this patch in, I don't know, 20 parts when it's already there, ready. So it was registered in the US. It was never registered in the US because they say that it's a lack of long-term safety data. So they decided not to register it back in 2004. So it was some time ago. In the European Union, it was used and it existed, but it disappeared from the market in 2012. And the official reason is commercial one. So they didn't benefit enough from that. So maybe it's something that is going to come back to the market. So you just like, if you see some use on that, maybe it's something that was already there. I don't have so much time left, but I want to just refer you to guidelines. There are not so many guidelines on management of menopausal symptoms in patients with gynecological cancer, after gynecological cancer. So basically, you shouldn't read all of that. It just like proves what I already said. Testosterone that we have on the European market, we can use only off-label. We can use it only for so-called hyperactive sexual desire disorder, and that's something that we need to communicate with a psychiatrist or psychologist, because this is a diagnosis that maybe we need some help to give a patient. And once again, estrogen, testosterone always go together. You cannot, if it's not okay to have estrogen for you, then it's not a discussion to have a testosterone. What I really want to warn all of you who are listening, and please spread a word, is about like dietary supplements. There are a lot of like herbal dietary supplements that you can buy. In certain countries, they're very popular, like in the US, when you enter a pharmacy, it's a lot of different dietary supplements. And they say herbal based, phyto, etc., etc. The thing that it's not controlled how much substance and how much this active substance is in every tablet or in every pill. that they sell. So you should be really careful with that and absolutely avoid it. Use only legal options and not using this off-label these things that are not considered to be drugs. Of course, there should be a holistic approach, and we should consider different aspects. So I think there is some problem with my presentation. It doesn't move. But anyway, it should be a holistic approach. We shouldn't think, okay, I don't have libido, I should just get testosterone at once. No, it should be, we should look at the medication that you have. Maybe you just have a simple depression, so you need to get an antidepressive, antidepressants. Maybe it's something else. So it's something that shouldn't come first. It's not like a first resort, it's the last resort or one of the last resorts. Yeah, I think my presentation is frozen, but I can, yeah, here it comes. And maybe, yes. So once again, testosterone is a precision tool. It should always go together with estrogen, and the dialogue about testosterone should be opened. If you have any questions, if you wonder about something, ask your doctor or contact us. You can do it here or using our emails. So that was all. Thank you so much. And if you have any questions, send them in the chat. I reply to you there. Thank you very much.
Thank you so much, Zoya. I think sometimes we think so simple that we need a pill to solve our low libido, that we need just testosterone to solve our libido. So it was very useful. It was an excellent presentation. Thank you so much. Okay, and go to the next speaker. Professor Dr. Laszlo Ungár is a gynecologic oncology surgeon and a university professor, one of the pioneers of gynecological oncology in Hungary and in the world, and the co-founder of the National Training Program in Gynecological Oncology Surgery. One of his most significant innovation, which has since become part of international surgical practice, made it possible to remove cervical cancer in young women while preserving fertility and even in certain cases to carry the pregnancy to term. This is the trachelectomy Wertheim art. The development of this groundbreaking technique involved Dr. Laszlo Pálfalvi along with some other colleagues, but the first such operation was performed by Professor Laszlo Ungár and Dr. Laszlo Pálfalvi. He received the Ernst Wertheim Award. Today, his name is recognized and respected worldwide. He's going to talk about a very sensitive topic, I can say, which is the vaginal construction surgery. We are very happy to have you on board. Professor, please go ahead with your presentation.
First of all, thank you very much for inviting me to this fantastic ENAGAGE meeting. I must tell you that I enjoy it. So being here as an audience is also must be excellent. If I would like to put into a short sentence what I think is the reason, the goal, the option of replacing or reconstructing vagina, then I'm sure that an important part, an important step of achieving sexual health is this very primitive technical question. Having a vagina certainly helps a healthy sexual life for gynae cancer victims, even if this surgical techniques, surgical inventions are, first of all, are not only for cancer victims, but for women who are, for some reason, were born without a vagina or lost the vagina. If I try to go through quickly the indications of new vagina or vagina creation, then there is a whole group of diseases and embryology problems which makes new vagina surgery necessary. The most frequent condition when vagina is missing is the MRKH syndrome, but there are some other embryologic conditions like the urinary tract, skeletal, vertebra, congenital anomalies. All of this is not oncology, but common with the absence of the vagina. There are indications for neovagina which are treatment related or treatment toxicity related. This is a numerous group of patients who are helping to maintain and develop the optimum artificial or created vaginas. Pelvic exenteration and vagina removal are naturally belong to this group of patients. Vagina pre-malignant or malignant conditions, loss of vagina caliber, lubrication, and flexibility following radiotherapy is probably the most frequent condition which is in need for reconstruct or reshape the vagina. We heard a very interesting and detailed presentation of from our first speaker, but I am just a simple surgeon, so I would like to move on the technical level. So if we go back to see how long this problem is in humanity, it's unbelievable that there is literature written 500 years ago about the problem of missing vagina. The creation of a vagina is having a 150 years long history. Lots and lots of surgeons, descriptions, surgical procedures which improve the sexual health. So it wouldn't be possible even to go through the list of surgical interventions. So I chose a couple which are in use in most big gynae surgical centers. So let me go through of these procedures with you, and I will try to to highlight the advantages and the shortcomings of these surgical techniques. These are the of course, these are selecting the procedures from a huge haystack of operations. First one I would like to mention is the Vecchietti procedure. It's not very new, not very old. Anyhow, in this procedure, a tension suture is used to create perineum vagina. It is definitely a big advantage that this procedure doesn't need an open big surgery, no cosmetic distortion. On the other side, it has some disadvantages, no potential for lubrication. Prolapse is a risk because technically it is impossible to anchor the neovagina in the pelvis. And last but not least, progressive dilatation necessary throughout the sexual active lifetime. Okay, let's go to the next one. This is the Mackindo procedure, probably one of the most frequently used neovagina technique. In Mackindo procedure, we are using a half thickness skin flap fixed onto a mold. Usually this is a single-use vagina mold. And the whole operation or the surgical activity is on the perineum. Abdominal part of the surgery is not existing, so it is a low-risk procedure. Disadvantages is first of all connected to the donor site of the half thickness skin flap. It is healing with pain. Changing the bandage on it is also a horrible, painful exercise. No chance for success with this Mackindo procedure if any surgical or radiotherapy or any previous attempts of vagina creation has happened already. So it must be first or nil. Another risk is that vaginal length and caliber is pretty unpredictable. And now I'm coming to the most important shortcoming of this procedure and some other procedures I will talk about, that several publications proving that there is a cancer risk in the neovagina. And it means that if someone is having a Mackindo vagina, cancer screening is important. The gracilis flap, gracilis myocutaneous flap. This is the gracilis flap is a well-vascularized, bulky, large volume flap, and we push it into the pelvis through the opening of a total pelvic extent. Advantages of this procedure is absolutely important to mention because it is a prevention of the empty pelvis syndrome. Empty pelvis syndrome is a life-threatening condition, and we try to avoid it. Gracilis flap is a guarantee against it. It can be a two-phase surgery. I mean, operating the huge intervention of the pelvic exenteration. Then we let the patient heal up, wait some months, and after some months, it's perfectly possible to create a gracilis myocutaneous flap neovagina. Disadvantages: it is a major surgical intervention on the thighs, on the medial aspect of the thighs. It is a huge scar and definitely negative cosmetic consequences. Ileum, neovagina, I think it has much more drawbacks than advantages. Only advantage is that it is a small bowel neovagina and a small bowel surgery, which means that it is not high risk procedure, but the use of the small bowel neovagina is risky. It can rupture, it can bleed, and it can prolapse, which is a difficult to accept condition, even if it is going through corrections. Okay. Sigmoid colon neovagina is probably the most frequently used neovagina. By the way, I am not considering it the best one, just frequently used. Sigmoid colon is having a long mesentery, excellent blood supply, but on the other hand, the irradiated large bowel is tending to develop necrosis, fistula, decrease of caliber. So it is in and again the neovagina prolapse is a big problem, difficult to correct it. So it is extensively used, but I am discouraging colleagues to use this type of neovagina. Cecum neovagina. Cecum is the most frequently used by our team. Fortunately, the cecum is at the edge or the border of the radiotherapy field, so even excellent for previously radiotherapy treated patients for neovagina. Cecum has an optimum caliber and lubrication for functioning as a vagina. Prolapse is practically non-existent in this type of surgery, and which is very important that if someone had an operation or an intervention to gain back a neovagina, and the procedure is somehow somehow non-functional, needs a reoperation, then cecum neovagina is perfectly suitable to be the target of a second surgery. Disadvantage, yes, it's a big operation, a large bowel surgery. But this is, regarding my best knowledge, this is the only disadvantage of cecum neovagina. Okay, and then if you would fear that it's still not I still not generated enough fear. If we are looking at the consequences of neovagina in general, then it is an accepted consequence of neovagina that approximately 15% of patients will develop diversion colitis that needs treatment, and this treatment is long-lasting, recurring problem. It can be treated by short-chain fatty acid irrigation and mesalazine therapy and corticosteroid enema, but long-term symptom-free condition is difficult to achieve. And again, cancer in the neovagina. In 2007, it was published that someone collected from the literature 200 cases of cancer in the neovagina. The thing is that it is a warning that I am trying to pass over to all of you, that cancer screening is paramount in neovagina. This is just a short description which steps we make when we create this neovagina. It's interesting more for practicing surgeons, but anyhow, we create the space first, then we mobilize the cecum, we separate it from the functioning bowel, and ileoastendoscopy is created. Neovagina is implanted at the end, and it's relatively easy to stitch together the perineum and the cecum vagina. Oh, sorry. So it's an easy to perform procedure. Tension-free anastomosis can be expected, and if it is tension between the neovagina and the introitus of the vagina, for some reason this cecum tolerates it well, which is absolutely unique. No other neovagina is having this very friendly nature. So it's an excellent bowel anastomosis site. We have one advice, again, it's for surgeons, that cleansing the neovagina before it is harvested onto the perineum can spare some difficult cleaning procedures, and it is obstructing the inflammation in the neovagina, which is painful, inconvenient, discharging. It's another very surgical feature of this perineum so it is again an excellent feature of this neovagina, that even if the patient was previously operated and the neovagina operation failed, cecum neovagina can replace it, and it is tolerating the scarring environment. I advise to choose the surgical intervention with prudence. So main fields of indication, primary reconstruction that I mentioned already. It's post-radiotherapy, vaginal repair is also possible with cecum vagina. I suggest that before making plans for a neovagina surgery, think it over and choose the optimum one carefully, and spend some energy and time for this choice. And it is, I think it is just as important, at least on this forum, that I suggest patients to consult a specialist and try to get or to collect information about the options of regaining vaginal sexuality. Because if you sit in an oncology clinic where people are coming to have a cancer screening or complaints or what have you, encourage your patients to consult a specialist in view of regaining this vaginal sexuality. Okay, and thank you for your attention.
Thank you so much, Professor. It was really, really interesting I think this vagina reconstruction surgeries, especially after gynecological cancers, involves many sacrifice. And just please note for everybody that we don't want to give false hope, but also we don't want to take the opportunity from the ladies. And I think this topic deserves more and more information and discussion in the future too. So thank you so much. So let's go to the last presenter, and we are here, many of us, so we are very unwavering. It's great. And this is Richard Toth, a gynae surgeon at Semmelweis University, Department of Obstetric and Gynecology in Budapest, as a dedicated person specializing in gynecological oncology. Dr. Toth is an active member of the European Network of Young Gynae Oncologists, the ENAGAGE. He is a honorary member of the Mellowflower Foundation, and he is also deeply committed to improving patients' quality of life, including work on sexual rehabilitation. The stage is yours.
Thank you very much, and thank you for the welcoming and the invitation to speak about my topic, which is going to be the follow-up care after vaginal reconstruction, which is, I have to admit it was a bit difficult to collect the data because data is quite scarce in the field of gynecological cancers, because we can only extrapolate data from gender affirmative surgeries mainly, and these interventions what we have to do to prevent and to treat these complications is comes a lot of times from here. Okay, let's start. So I would like to find the goals to admit it, although we have already spoken about it. So there is an aim to get an anatomic reconstruction, to recreate a new vagina, to prevent fistulas after a surgery, or to have a support which is big enough to prevent empty pelvis syndrome, which can happen sometimes after exenteration surgeries. There is a functional restoration, and which is very important, is the psychosocial quality of life and quality of life goal to support the body image and to reestablish the self-esteem and the sexual identity and the intimacy of our patients. There are plenty of surgical interventions. I just made a list. If you would like to check it later on online, then you can just read it. But the important that we have those local and regional flaps, which are mainly used in those situations when there is a previous radiation therapy or operation. Those are the ones that might be good to use. So complications, without an extensive list of these complications, I just collected some, and I would like to go through all of these and what kind of complications we can have. And we really have to keep in mind that besides the anatomical complications or the medical complications, there are the psychosexual complications, which are even more important and even have to be emphasized. So we always have to address it. We always, when we control these patients, we always have to ask it actively whether they have problems in this manner as well. So first of all, if you do an intervention, a surgical intervention, there is always a chance of having a wound infection, or if you are dealing with flaps, there is the chance of developing a dehiscence. Those complications are quite related, so you must know that there is a kind of an infection that comes from bacteria, which is in the genital area usually, and we have to treat it like that. So there is in the treatment of that, there is antibiotics, irrigation, drainage is important, and sometimes endoluminal vacuum therapy can be a good solution to treat these patients. If it goes further, then it can cause graft necrosis or the necrosis of the flap, which can be a bigger problem, because the thing that we've done during our surgery, we did for nothing, because the flap that we reconstructed the vagina is going necrotic and going to die, and in this manner we have to do something with that. So if there is a partial loss, we can do re-exploration, we can do a secondary closure afterwards, or if there's a total loss, then we should have to think about secondary reconstruction after a primary reconstructive surgery. Fistula formation could be another big problem. Fistula formation, you might know fistulas are just like tiny little channels between different organs. In this manner, this can formulate between the bladder and the neovagina, or between the intestines, mainly the rectum and the neovagina, which can make problems and can cause continuous loss of urine or fecum. For this reason, we really have to check the patients after the surgical intervention to recognize these. As you can see, in the early phase, there is chance for conservative treatment, but if it's a recurrent or it's an irradiated field, then perhaps we should have to think about flap interposition. So we have to redo our surgery again. Vaginal stenosis is a contracture. I really wrote a really impressive picture here, but it was shocking, so it was decided to take it out rather. So it can be really a big stenosis. It is the other point we really should have to think about the during the follow-ups. So there should be a mechanical dilatation protocol. You should have patients who has undergone these kind of surgeries should use regularly, and it's really important to say regularly, the mechanical dilatation, as Catherine has said, for a long time. Topical hyaluronic acid could be a good choice as well to help the regeneration of the flaps as well, and even manual or surgical revision, if it's necessary to dilate in really severe cases, could be an issue as well. Chronic discharge or mucorrhea is rather like complication of bowel neovaginas, which means that usually it's more emphasized in large bowel neovaginas, because the mucus production of the bowel goes on, and it will cause this kind of chronic discharge, which can be quite annoying, as it can be the mucus itself the amount of mucus can cause a severe discharge. So for that, there are some other kind of antibiotics we can use, or regular irritation could be a thing that we can use, or if it's really annoying, then perhaps a mucosectomy can be a intervention that could be done for these patients. Neovaginal prolapse, Professor Ungar has already mentioned it. It can be kind of severe problem of these reconstructive surgeries. There is some kind of underlying issues behind this kind of complications, so the loss of apical fixation or a weak pelvic floor support, even when there was an exenterative surgery, for instance, and the pelvic floor muscles got injured, it can be a problem for it as well. Increased intra-abdominal pressure or graft elongation can be the reason why it happens. What can we do? So we can do conservative management on the one hand. It can be pelvic floor physiotherapy, or a pessary, what we can use, or then if there is still need for that, the surgical correction could be a solution for this problem. With that, we can use apical fixation, but usually, according to the literature, it's rather perineorrhaphy or perineoplasty that can be used. And what can we do to prevent it? We really should have to intraoperatively care. We should have to secure the fixation of the neovagina. We really have to measure the length, and we have to avoid that it could be excessive. And the reinforcement of the pelvic floor is really important in this field. Postoperatively, patients should have to avoid the intra-abdominal high pressure. So the avoidance of constipation and heavy lifting is important. A pelvic floor physiotherapy should be done, and monitoring is really important for the recognition of the early consequences. If there's a common complication usually when they use flaps, which are covered with the normal skin, because the lubrication is not occurring, so there could be a dryness, pain, and dyspareunia because of that. So patients should have to use lubricants or moisturizers during the intercourse. It's really important to check for the osmolality and acidity of these lubricants. Trigger point massage can be and desensitization could be a thing that can be done with pelvic floor physiotherapist. And if there are some chronic pain, neuropathic pain agents could be used as well. But it's really important to have a psychosexual counseling during the whole treatment. Neovaginal hair growth is a thing that we should have to talk about. It's not that common, but it can happen. Sometimes it can cause chronic folliculitis with abscesses, and it can be behind a recurrent discharge, odor, or infection. What we can do is really important when we choose the field where we are taking the donor site, where we are taking the skin from. It should have to be there should have to be a laser hair removal done before and electrolysis, and it can solve our problems before. Sorry. And we don't have to forget the malignant diseases of the neovagina, because it's really important after gynecological cancer surgery to go on with the regular checkups for the neoplasia that was there before. And perhaps it was the neovagina was made from a part of the body which had received some radiation, for instance. If there is a bowel that has been in the radiation field, it can have like more chance to develop malignant disease. And chronic irritation, inflammation, or mucus stagnation can be a reason behind those. We have talked about the neovaginal problems, which we have to talk a bit about the donor site morbidity. It can be a problem as well, because these kind of flaps that we use when we are talking about, for instance, the rectus abdominis flap, which is a quite big flap that we can move from the abdominal wall to the vagina to recreate a neovagina. It's well vascularized, but it means that we are and taking out the part of the abdominal wall, which can cause hernias. So it must be done carefully, the reconstruction of the abdominal wall in these cases. If we are using a gracilis flap, for instance, muscle weakness can happen in the legs. So physiotherapy and gradual activity resumption is really, really important. And what Professor Ungar has told, that there is scar hypertrophy and the scar problems can occur. So we have to address these problems when we are talking about vaginal procedures. And of course, it's really important once again to talk about our previous topic, the psychosexual quality of life issues, because we really have to keep into mind that only 10% of those patients who has had performed a neovaginal operations usually return back to regular sexual life. So it's important to have a partner-inclusive counseling sessions which addresses the body image acceptance, and we really have to assess the with validated tools the problems that can occur. So what can we do as preventive measures? Preoperative optimization is one really important thing. So we really have to choose our patients who are eligible for these kind of operations, because sometimes there are some unrealistic expectations, and it can cause after a psychosexual distress if the result that they receive is not the one that they expected. So we really have to discuss in really, we have to go into details about what they can expect and what can happen afterwards, to not to get not to get a delusion after the surgery. We have to control the infection and the inflammation. We have to do a nutritional and metabolic optimization to prevent healing problems after the surgery. And of course, we have to keep the patients under oncologic control. There are some intraoperative strategies which are important for the surgeons. So the techniques should have to be so meticulous and so precise that with those we can prevent the complications after our surgeries. And in the immediate postoperative care, we should have to take care about the positioning. So we have to avoid the direct pressure on the flap on the one hand. We really should have to think about the urinary catheter or fecal diversion if it's necessary in kind of operations when it's high risk to develop a fistula. Prophylactic antibiotics should be used a bit prolonged, and negative pressure wound therapy could be a good solution to support the graft. Early nutrition and physiologic mobilization improves perfusion, which helps healing, and pain control should be done without vasoconstrictive agents. On the long-term rehabilitation and the maintenance, it's really important that the patients should use vaginal dilation regimen, which should have to be initiated 6 to 5 weeks postoperatively, and it should be done at least for 6 months, but as Catherine told, for much longer time. Topical estrogen, if there is some vaginal tissue left, could be a good solution as well to use, but otherwise hyaluronic acid could be one. Pelvic physiotherapy is important. Regular follow-up and imaging is important as well to check for recurrence, infection, or malignancies occurring in these vaginas. And of course, psychosexual support is important on a long term and not just for short term. On the when we are talking about donor side morbidity, how can we prevent those? We should have to do a vascular mapping regarding to that field. We can use drains and compression with physical therapy, and we have to minimize the flap width to preserve the contour and the function, and to have good cosmetic results on the donor side as well. And our follow-up measures has 3 different aspects. So there is one is an oncologic follow-up, which just how it has to be done according to the disease-specific guidelines, what was done before the reconstructive surgery as well. It has to be a follow-up regarding the reconstructive surgery itself, and the sexual health should be reassessed, and the psychological aspects has to be reassessed. So I just made just like a follow-up that could be used. So what can we do in the first 6 or 8 weeks? There should be done a wound inspection to check everything's fine with those. We should have to assess the flap or graft viability. If there is a catheter drain, is there any use any longer? Pain control is important. Bowel function monitoring is important, and the initiation of vaginal dilator therapy is an important issue at the first follow-up after the surgery as well. There is an intermediate follow-up when I can't go back, I think, but yeah, there is it. So we should have to use a speculum to check and evaluate the final length and the epithelialization of the new vagina that we have had. We should have to assess the stenosis, the continence, and we should have to encourage the patients to continue the dilator regimen. And the scar management is important. So for that, physiotherapy massage should be done, and it is a time to start counseling sexual health issues, and try to encourage our patients to return to their sexual life. And on the long term, we really regularly should have to check the vaginal length to prevent the stenosis. We should have to check the mucosal health, the lubrication. We really do have to assess on the complications if there are ones, like granulation tissue or ulcerations, fistulas, whether there are recurrent infections or discharge. Oncologic surveillance have to be done according to the specific oncologic guidelines. And as I've already said, and it's really important to address the psychological issues as well. And finally, I would like to speak some words about the future perspectives, what can be done and what can be our hopes in the future. So there's tissue engineering or regenerative medicine could be one thing that can help our patients to have bioengineered scaffolds or mesenchymal stem cells that can help to have a better integration of these created neovaginas. For instance, there are these decellularized off-shell matrices which can be done with the patient's own cells. It can be an immune-tolerant autografts, just like transplantation. And problem which can happen usually that there is the innervation of this flap that comes from other part of the body, causes a strange sensation during sexual intercourse. So there can be neuronized flaps that can reconstruct the innervation of these flaps from the pudendal branches to have a very similar feeling that it was before the operation. And what else can be expected? There is one initiative to use the endoluminal vacuum therapy. So, for instance, when the operation happens in 2 sessions, in the first session and the end of the first session, there is an endoluminal vacuum therapy. It helps the tissue around the neovagina to produce new vessels and to have more growth factors and get a better oxygenation. And in this manner, we can prevent the complications after neovaginal surgery. And there could be as well immune silent grafts what can be expecting for in the next few years. And the last slide of mine, it's really important to emphasize that in the management of these patients, multidisciplinary team is the one that ensures the best outcomes, even in the field of prevention and even in the field of complication management. And I would like to thank you for your attention.
Thank you so much. It was really a very detailed and important lecture, and I think we learned a lot from it. Now the poll is too quick, but maybe just I think we answered all the questions you raised in the chat and the Q&A section, and you can find also the email address of our experts, and also you can contact ENAGAGE anytime. I think it is quite late now, so we can close our webinar with the last poll. So please answer the poll. After today's session, how do you feel about the topic of sexual health after gynecological cancer? More informed and confident, more connected and inspired, still curious and having questions, and grateful for the open conversation. This is also a feedback for us, so thank you for using the poll. Okay, see, more informed and confident, more connected and inspired, and grateful for the open conversation. Thank you so much for your answers. And I really just would like to close the webinar with our purple flower. And I really want to thank you for our sponsors who are supporting Quality of Life project. And in the arm of the Quality of Life project, the sexual health webinar and the previous one. So thank you so much. And I think we can say goodbye and really thank you for your unwavering that you are unwavering and you were here till the end of the webinar. So contact us anytime and we will continue this topic because this is very important. Have a good night for everybody.